I'm going to do a quick review on SOAP notes. And documentation isn't the most scintillating subject, of course. Most of us aren't saying, wow, well, I really don't like doing the interventions, but I love doing the documentation. It's just the other way around. All of us love doing the physical therapy interventions, and the documentation is torture. Not really torture, but it's a necessary evil. So particularly in this day of electronic medical records, everybody can read your notes. So you have to make it organized, legible, or easy to read if it's an electronic format. And the doctor, it could be reading your note. She might be looking for some particular information. The patient could be reading your note, and they can actually come back and say, hey, that's not true, I want you to change that. So be aware of that. The insurance adjuster is reading your note to see if they're going to pay you for what you said you did, and that what you did is skilled therapy. So a lot of different people, and then the next therapist who sees your patient, whether it's you or your PT or another PTA, they have to figure out from your note what you did, how the patient reacted to it, and what the plan is to go on. So documentation is pretty important. It's kind of the hub of communication for everything. It's important for continuity of care, it's important for reimbursement, it's important for communication among different healthcare providers, and it's important for communication with the patient. So as much as we might not be thrilled about doing it, it's something that we have to get good at and get efficient at, and really know how to organize our notes. So the learning objectives, of course, for this little lecture are to be able to accurately document PT interventions in a SOAP note format. So here's some helpful tips for writing SOAP notes. You're going to be writing a SOAP note for all the patients you treat, whether you're in the lab, at school, or in the clinic. So for in the lab, for each case study or lab practical, you're going to be provided with information that is similar to what you would see in a PT initial evaluation. And using this information, you are either going to need to perform the treatment or imagine the treatment that you would perform, and document the imaginary treatment if it is imaginary. In school, of course, there's a little bit of creative writing involved because we don't have real patients with real injuries, and we're going to have to make a few things up. But in the clinic, of course, we only want to document what we actually did and how the patient actually responded to it. So there's a little bit of disconnect between how we do it in school and how we do it in real life, because we don't actually have injured patients in school to work with. So that, just think of it that way, is imagine that you do have an injured patient and how they would react to it. But in the clinic, of course, you're only going to document what you did. So in the subjective section, the first section in a SOAP note, there are some organizations that have adopted a different order of the same things. So for example, in the I work in a hospital-based outpatient clinic, and in the clinic where I work and throughout our hospital system, we don't use SOAP, S-O-A-P, we use OPSO, A-P-S-O. So assessment, plan, subjective, and objective is last. And then we sort of have a little section where we're talking about charges and why we did what we did. So a lot of times when the doctors are reading our notes, they're looking for something. They're looking for the assessment. It's first. They want to know what you think about how this patient is doing to meet their goals. So a lot of times they don't even want to read the rest of the stuff. They just want to read the assessment, and that's why the hospital chose to put it at the top. So in the subjective section, though, in a classic SOAP note, it's at subjective, objective, assessment, and plan. So the patient might tell you a lot of things that are not relevant to document. They might tell you a lot of things that are relevant to document. So the kind of things that you want to put in the subjective section are the patient's chief complaints. My knee hurts. It hurts more when I walk. It hurts less when I sit. Okay, that's good stuff to know. Their current complaints. Well, yesterday I was feeling pretty good until I went out to work in the yard because it was such a nice day, and now my knee's really throbbing. I had a hard time sleeping last night. That's a current complaint. Their goals. I really want to be able to do all my yard work this summer without knee pain. That's a goal. Functional status or activity. What they're doing that aggravates it. Like they're still able to work in their yard, but it aggravates their knee pain. Social history. Well, I just, my husband passed away last year, and we used to do a lot of stuff together in the yard, but now I have to do it all myself. That's something that's relevant. Employment status. Are they retired? Are they working? Is their injury affecting their work? Maybe they have to be on their feet all day, and it's really challenging for them. Their living environment. Do they live in assisted living? Do they live in an apartment? Do they live in a house with a gigantic yard? Do they have a lot of stairs? That sort of thing. Their general health status. If they mention other health issues that may affect the thing you're treating. Social and health habits. Are they getting good sleep? Do they eat well? That sort of thing. They might mention those things. You're not going to put all these things in the subjective section, of course, but these are just some examples of things that might be relevant to document. The patient's health and medical history. If somebody has diabetes, they're going to heal more slowly. If somebody has heart disease, you're probably going to adapt your exercise that you have them do, potentially. If they have other health issues or something in their medical history, well, I had a knee replacement 3 years ago. That's relevant. The patient's stated response to the last PT treatment. So they come in and they go, man, I was sore for 3 days after the last session. Can we tone it down a little bit today? That's pretty important to write in the subjective. It's how they reacted. And a lot of times in the previous note, in my plan, I might have written, assess patient's reaction to today's treatment as my plan. And so that's really good relevant information, subjective. And then their current pain levels. There's a lot of focus these days on assessing people's pain levels. We'll talk about that later in neuro, or maybe we already talked about it if you've already had neuro. But sometimes by focusing on people's pain, you can actually make their pain worse. But a lot of clinics and hospitals and systems want you, and insurance reimbursers want you to document pain levels, and that is subjective. Okay. In the objective section, lots of things. So remember in tests and measures where you all the stuff you measured, that's all objective information. So sensation, strength, balance, skin integrity, inspecting their skin if they have an orthotic or something like that. Vital signs, test results, range of motion, posture, transfers like level of assist needed in transfer, that's objective. Or what equipment they're using for a transfer. Like, modified independent transfer with a slide board. That's a good objective thing. Edema or girth measurement. So you're tracking whether or not their edema is going down. Neurological testing, proprioception, cognition, and outcome measure results. So you did the Berg. You put the Berg score in the objective section. So in the notes that the forms that we have you use in lab, there is a separate section for objective and treatment. Even though treatment is in the SOAP format is considered part of the objective, it's what you did. So in the treatment section, you don't just want to document what you did and the parameters involved, but also why you did it. You want to say what part of the plan of care are you addressing with the interventions that you performed. So, or what part of the goals are you addressing with the intervention you performed. So, say one of their goals is to increase their range of motion by a certain amount. So you did a certain exercise with them. So you said, oh, I'm going to do this exercise to increase range of motion of the right knee. So you want to say why you did it, not just that you did it. And the other thing too is, when I was in school, they used to say, with documentation, oh, you really want to paint a picture of the patient. Don't say what you did, say what they did. Okay, it's completely turned around now. You want to say what you did. It's almost like you're telling the insurance company, this is why you're paying me. This required the skill and judgment of a therapist. So you're documenting skilled treatment that you're going to get reimbursed for. So what you did and why you did it. Pretty important. The assessment section, we want to talk about either areas of improvement or areas that need improvement. So what's limiting the patient's progress towards their goals, or what are the patient's areas of improvement? So you might list what the existing problems still are. You might say what progress they've made. The patient's motivational level, that could definitely affect their progress. It might be limiting their progress toward their goals, or it might be helping it, hopefully, if they have good motivational level. You want to say if they've met either short-term or long-term goals. Like you can say, oh, patient met short-term goal of increasing shoulder range of motion by 10 degrees. Yay. So you're showing that, yes, what we're doing is meeting goals. And then you want to say what's still lacking to achieve the goals. So say, patient was able to actively flex right shoulder to 140 degrees today, but is still most restricted in abduction and external rotation in a capsular pattern. So maybe we need to do some things that are going to affect the joint capsule. So you want to say how the PT intervention is helping or benefiting the patient. So you might say, and this is sort of borderline subjective, but you might say, patient reports decreased pain from 5 out of 10 to 3 out of 10 during today's treatment. So the patient reported a direct decrease in pain. So that's what you're not really reporting that subjective information, but you're saying, look, what we did in PT is helping and benefiting the patient. Or you could say, patient reports return to a certain activity without pain, or something like that. Or patient has met the goal of being able to walk 250 feet to the dining room in their assisted living without assistance, something like that. So how is this helping the patient? The reaction to today's treatment. So patient was able to perform all exercises instructed today without reports of increased pain, something like that, and the goals. So you really, really, really want to talk about goals in the assessment section. And really when the lab instructors are grading your SOAP notes, they're going to look for that. They're going to look for you to address goals. The plan section includes the plan for the next visit. Changes in interventions, possibly discharge plans, and that can include specific plans for progressing therapeutic exercise. So you want to say, I'm going to do this exercise next time. So you'll, in the plan, you'll say, progress to standing knee extension next visit, something like that. They have been doing seated knee extension. The location of treatment, particularly if it's changing. So maybe we've been working on their knee, but they also have in the referral, it's for their knee and their shoulder. So we're going to focus on the shoulder next time. Say, patients progressing well with knee strengthening exercises. Next treatment will focus mainly on the shoulder, something like that. Plans for further assessments. So reassess Berg balance test next visit. That's a good one. Anytime you want to reassess something, and this is, you're either writing a note to your future self or the next person that's going to see that patient. Activities to try next PT treatment. If you had a great idea, but you don't have time in this session, put it in the plan because you won't remember. And if somebody else is seeing the patient, they'll go, oh, that's a great idea. I'm going to do that. The treatment progression, particularly if you're following a specific protocol. So some protocols might say weeks 1 to 2, this is what you're going to do weeks 3 to 4, especially orthopedic surgical protocols can be very specific about when they're going to progress, or progressing weight bearing. So sometimes we're waiting for the surgeon to clear them for weight bearing or a certain percentage weight bearing. And so you'll say, next visit, progress to weight bearing as tolerated, add proprioception and kinesthetic activities. You might say discharge planning. So say recheck with primary PT next visit and consider discharge. Or 2 more visits before discharge, or something like that. The one thing you never want to say in the plan section is continue PT plan of care. That is just, don't say it. It's too vague. You might say how you're going to continue the PT plan of care. Like you can say, continue with therapeutic exercise and progress as able. That's a little less vague. It's still kind of vague. I want some more specific activities in there. You could say progress to closed chain activities next time. That's a little more specific for therapeutic exercise. So it's really interesting that I have a lot of PTs in the clinic where I work. There are like 16 of them, and I could conceivably see any one of their patients. And some of them have the super vague plan, something like continue skilled PT. That's one that one of the PTs likes to write. And some of them have a super specific plan laid out, which it's great. And you can have somewhere in between. So if somebody says, continue with manual therapy if helpful this session, or something like that. So you're going to reassess, you're going to see how they did after the last session and see if that was helpful. Sometimes the patient will come in and say, that didn't help at all, or boy, it made it a lot worse. And so you're probably not going to continue with that. You're going to use your clinical judgment to do that. But be as specific as possible in your plan. And the lab instructors, when they're grading your SOAP notes, they want to see a specific plan. What activities are you going to do next treatment? How are you going to progress their thorax? So make it as specific as possible. And seriously, when I get one of the PTs that writes a really super specific plan, that's a dream. I just love that, because and that doesn't mean you're not going to change it a little bit, or you're not going to you're going to have time to do all that stuff. But it gives you a very clear indication of what you want. And one of my I always call them my PTs, but one of my PTs who writes super specific plans, she said she does it because it's a way for her to remember. So she does it whether I'm going to be seeing her patient next or whether she's going to be seeing it next. She says, this is what I want to do, and I'll never remember it if I don't write it down. So you can think of the plan section as that, is a reminder note to yourself, like, what am I going to do next time? Or a reminder note to the next person that's going to see them. So in the plan of care, you never want to write continue PT plan of care. And in the assessment, you never want to write patient-tolerated treatment well. That is a very vague statement, and who knows what that means. Will you see that when you go out in the clinic? Absolutely. Do you want to do it? No, you do not.